Good afternoon, everyone. Welcome to our August webinar. My name is Kathy Nickham. I'm the Director of Education for the DPC Education Center. And today we're going to be talking about dialysis vascular access. Before we get started, just a couple of reminders for you. All of your lines are muted throughout the program, and you will be able to type questions in the chat box, and we will answer them at the end of the program. You're also welcome to make comments in the chat box throughout. We will have, probably within a week, the webinar recording and the slides. They'll be posted to our website, so those will be available to you as well, and you can share those. And we also encourage you to complete the brief feedback form that will come up on your screen at the end of the program, and we appreciate your thoughts, your suggestions, and there's a place to give us potential topics for additional webinars and topics for our newsletter. So as we get started today, I would like to introduce Dr. David Mahoney. I am especially happy to introduce him. He is a member of our DPC Ed Center Advisory Council, and we have been working hard to make this program happen. And he received his nephrology training at Walter Reed Army Medical Center in Washington, D.C. And he's been a practicing nephrologist for nearly 30 years. He's a fellow of the American Society of Diagnostic and Interventional Nephrology and was the Chief Medical Officer for Lifeline Vascular Care before assuming his current position as the Chief Medical Officer for Hospital Services for DaVita. Dr. Mahoney, I'll turn the program over to you now.
Great. Thank you very much for that kind introduction. And again, I'm very delighted to be able to have this presentation today. Vascular access is one of my passions, and one of the things that I think is so exciting is to present it to this group, because the dialysis patient citizens group are people who take charge of their own health care, and that's so vitally important in the world of dialysis access. So I'm going to go ahead and start here. As you said, there will be time for question and answer at the end. This looks like a pretty hefty list of learning objectives. Some of the things we actually will go through pretty quickly and approach from a very high level, just to give sort of some background. Most of you probably are very familiar with most of this. Some of it I hope will be new to you. We'll discuss very briefly the functions that dialysis performs when your kidneys fail. And what I'd like to focus on is the importance of things that you need to control yourself that dialysis really doesn't control well, and we'll touch briefly on that. We'll talk about the different types of dialysis, again, very quickly. A very brief discussion of how a hemodialysis machine works, and I would be surprised if very many of you have ever actually had a presentation of what happens as your blood passes through that dialyzer. Why do you need a vascular access for dialysis, for hemodialysis? And we'll go over the different types of dialysis vascular access, why catheters, although they are very common, they are the least preferable form of access, and we try very hard to eliminate catheters when we can. And then we'll talk about the important things for you to know about your fistula or graft, and how you can take a very active role in promoting your own health care and your own wellness. So, as we all know, and I think people think primarily that dialysis removes waste from the blood, and it does this rather inefficiently, but far more efficiently than did in the past when I started my fellowship 30 years ago. Our machines are better, and I think they are safer for you. It's also important to realize that one of the major roles of your dialysis is to try and restore a normal fluid balance to your body. And what's important is not to try and move fluid too quickly. And of course, the machine can only remove the fluid that is presented to the filter in your blood, but a lot, probably a third of your body water, is not in your vascular system, but is in your muscles and other tissues. And so anybody who has had cramping on dialysis, it's when a fair amount of fluid has been removed from your circulation, and then there's that shift of fluid from your muscles back into your circulation that causes the cramping, usually associated with some low blood pressure before that. If you control your fluid intake, that's a major, major safety issue for you, and controls your fluid balance, not only relying solely on dialysis, but your own adherence to your dietary restrictions. Dialysis, of course, corrects abnormalities in blood chemistry, but doesn't correct them all. And as you know, those of you who take phosphate binders and watch your diet so carefully, dialysis does a really poor job removing phosphorus, removing magnesium, removing those things that are found primarily within the cells rather than within the liquid portion of the blood and the plasma. And so although we can correct potassium and acid levels relatively easily, and to some extent correct sodium levels, things like magnesium and phosphorus, we have to rely on you, again, to watch your diet and take your medicines. Now, dialysis can be by hemodialysis, passing your blood through a filter, or peritoneal dialysis, where fluid is instilled into your abdomen and the impurities and other chemicals pass into the fluid, which is then drained and discarded. We won't be talking about peritoneal dialysis today. This is strictly a hemodialysis vascular access talk. When you begin dialysis, when your kidneys have reached the point that they can't provide enough function to keep you well, typically that's less than about 10% of normal kidney function. A dialysis machine doesn't do a heck of a lot better than that. And if you speak with people who were on hemodialysis and subsequently got a transplant, many times they'll tell you how remarkably better they feel. Well, the transplant kidney is far more effective. And so, again, we try and limit how much the dialysis needs to do by watching our diet and our fluid intake. But we also try and maximize what the dialysis can do, and having a good vascular access is important for that. And again, this is a team approach. You are the most important member of that team. Your nurse, your patient care technician, your dietitian, your social worker, your physician, everybody has to work together to figure out what's best for you. In my 30 years of practicing nephrology, I've never had that patient walk out of the textbook and come into my office. It's always somebody who's a little bit different. Now, how does a machine work? And this graphic is very, very basic. You've probably noticed when you go to dialysis that there are 4 tubes either going into or coming out of the filter. 2 of those contain your blood, and 2 of them contain the dialysis fluid or dialysate. So blood flows from your body, is pumped into the dialysis filter, where there are literally thousands and thousands of tiny hollow filters, and your blood passes through the interior of those tiny, tiny filters. They literally are the size of a hair. The dialysate or dialysis fluid passes on the outside of the fibers, and it flows countercurrent or in the opposite direction of your blood flow. That makes it more efficient for waste, chemicals, and water to pass out of your blood, pass into the dialysate fluid, which then essentially gets discarded. So why do you need a vascular access? Why can't you just plug the dialysis machine into a vein? Well, dialysis requires, for most people, a blood flow rate of at least 350 cc's per minute, about 12 ounces. And if you want to correlate how much that is, think about a can of soda pop. Most of those are 12-ounce cans. About that much fluid, that much blood per minute passes through the dialysis machine. So even if you are one of those people who has very large and prominent veins, they certainly don't provide for that kind of blood flow. You need to have arterial flow because the blood flow through an artery is much faster, and therefore a vascular access will allow blood to be removed from your body and returned to it at a rate that is sufficient to permit the performance of dialysis. I'd like to give a plug for the Kadoki group, which stands for Kidney Disease Outcomes Quality Initiative. This has been around for several decades now, and this is an organization that is formed with you in mind, you, the kidney care patient. The organization studies the practices in kidney care and really promotes better health, better care, and safety for patients with kidney disease. And their recommendations are not only for those who have kidney failure and are on dialysis, but those with pre-dialysis kidney disease. Periodically, typically about once a decade, the Kadoki Guideline for dialysis vascular access is published. Prior to the current volume, the most recent one was published in 2006, and the intention was to publish the update in 2016. The team went to exhaustive effort to come up with what I think is one of the finest patient-oriented publications that I've ever seen, and this was released in April of this year. This updated guideline contains substantial changes about how dialysis vascular access is approached. And in 2003, when the Fistula First initiative was begun, the real push was get a fistula in everybody. Everybody should have a fistula. Well, I think time has shown that although the vast majority of people are best served by a fistula, the better way to look at it is what they call the four rights. Get the right access for the right patient for the right reason at the right time. Very patient-centered. What's important about this is that you should be aware that these recommendations have changed, and you should take a very active role in planning your health care, planning your vascular access. And if I like to think of the life plan recommended by Kadoki as always thinking about what's next. So if you have a graft that is failing you often and you're going in and having it declotted every month or every couple weeks, it's time to start thinking about what's your next access and not wait until it's totally unusable. So I think most people are familiar with at least 3 of the 4 of these. What do we have for dialysis vascular access? How do we get into the bloodstream? Well, central venous catheters, and unfortunately about 80% of people start dialysis with a catheter. We'd like to see that number below 10%. An arteriovenous graft, which is a synthetic tube connecting an artery and a vein. HERO device, which basically stands for reliable outflow, hemodialysis reliable outflow device, which is a combination of a graft typically in the arm that people are familiar with an extension that extends all the way to the heart and bypasses any vein problems that people may have in the large veins in their chest. And finally, the access that we wish everybody had, which is a well-functioning arteriovenous fistula. So we'll start with a discussion of catheters, also referred to as CVCs, or central venous catheters. And as I mentioned, about 80% of patients begin dialysis with a catheter. It may be tunneled or non-tunneled, and I'll explain that with an image that's coming up on the next slide. The difficulty with catheters is that there are many difficulties with catheters. They have significantly higher rates of infection. Your likelihood of being admitted to the hospital because of infection, if you have a catheter rather than a permanent access, is about 12 to 13 times higher than with a permanent access. There are other complications such as catheters clotting, catheters becoming the source of bloodstream infection. There's a woman who works out of the Phoenix area now as an interventional nephrologist, and I believe she's the first one that I heard use the term, that little white tube of death, for central venous catheters. And although that sounds a bit melodramatic, I think it does show you how intently we really do wish to get rid of every catheter that we can. However, it can be the appropriate form of access for a tiny fraction of patients. And as an example, I'll give you a patient who begins dialysis urgently, did not have time to plan for a permanent access, but that patient has a kidney donor and is going to be getting a transplant in a couple of months. There really isn't much reason for that patient to get a permanent access. and the catheter is perfectly appropriate until such time as they get the transplant. So tunneled means that the catheter actually is passed under the skin in a tunnel before it enters the vein, and I'm hoping you can see my pointer moving. If not, the whitish part of the diagram on the left is where the catheter actually lies under the skin. The tip of it, you can see it says right atrium of heart. The tip of the catheter actually lies within your heart. And because these catheters are so frequently associated with infection, we are very, very concerned about the possibility of heart valve infection. And again, a great reason to avoid catheters if we can. A non-tunneled catheter, which is seen on the right, is typically what happens, or the catheter that is used when someone needs to begin dialysis urgently. And it typically is placed into the internal jugular vein, which is at the base of the neck, ideally on the right because it's a more direct path to the heart. And that catheter ideally should never stay in place for more than 7 days. And our firm recommendation is that catheter not remain in place for more than 3 days because of the very high risk of infection. Okay. So why do we think central venous catheters are so bad? Again, the bloodstream infection rate with a CVC is easily more than 10 times higher than with a graft or fistula, probably a couple dozen times higher. As I mentioned, the tip of the catheter sits in your heart, in the atrium, the top chamber on the right side, and puts you at very high risk for endocarditis or an infection of the heart, particularly heart valves, and formation of blood clots in the heart. As anybody who's had a catheter long-term can tell you, they frequently function poorly. They clot off. Fibrin is the organized, very, very tough and thick part of a clot that forms once the clot has had time to organize when it's been in place for a while. Many studies have demonstrated that fibrin begins to form on the outside of a catheter the day it is placed. And in the past, we used to do something called a fibrin stripping, where we would go in through a vein in the leg, pass a catheter all the way up to the chest. It would be a snare catheter, snare that sheath and pull it off the catheter. That was very complicated, met with a lot of patient dissatisfaction and patient discomfort in addition to the complications involved. Now typically the catheter is exchanged and the fibrin sheath ideally removed. Well, what happens? The catheter obviously is a foreign body. It doesn't belong in you, and your body recognizes it as being something that shouldn't be there. As soon as a catheter is placed, there's the beginning of inflammation in the vein. The veins tend to narrow down and try to isolate and close off the catheter, unfortunately at the price of sacrificing good flow in the vein. This narrowing of the large veins in the chest impairs blood return from the extremities, from the arms, and you may get massive arm swelling, and I have a photo of this coming up. Unfortunately, if a catheter does cause a significant narrowing of the central veins, the large veins in the chest, this can actually prevent you from having a graft or a fistula created later, because we know that the blood flow, the return into the chest will be impaired, and you'll run the risk of complications. Of course, when you have a central venous catheter, you can't shower, you can't swim, God forbid you get in a hot tub, and these patients demonstrated have a much shorter survival on dialysis. Now, that's a little bit artificial because some reviews will show that patients who have only a central venous catheter many times have a number of significant comorbidities, meaning additional significant health problems. But still, central venous catheters are definitely associated with a much shorter survival on dialysis. And of course, that's the last thing we want to see. So these are images which are taken from interventional radiology procedures. You could see the ribs. This is the right side of the chest in these images. And again, I don't know if you can see my arrow moving. I hope that you can. on the left side of your screen, that is a normal vessel. It is wide open. Now, the up above, you can see the shadow of the catheter, and down further down, you can see the tip of, or not the tip, but you can see the extent of the catheter into the vein. That is a setup for what occurs on the right. And when I took this image, I inserted this kind of hard to miss bright red arrow that shows that the catheter has led to an inflammatory response and the vein has all but closed down, so that you can see that there's dark contrast, and the dark black that you see is the intravenous contrast that is injected and then appears in the X-ray. And it just appears to stop where the tip of that arrow is. Notice that in the left screen, you don't see a lot of other veins. On the right-hand side, you see what are called collateral veins, because when this blockage develops in this vein due to the catheter, well, the blood has to go somewhere, and so it ends up engorging the veins in the neck and the chest, and these are referred to as collaterals. This image is what we hope not to see, this very unfortunate patient who had a catheter on the left side, which resulted in narrowing of the central veins, and because there's impaired blood return, that's associated with marked swelling. This is akin to what you may see in women who may have had mastectomy surgery for breast cancer and have the lymphatic system interrupted, where they cannot get drainage of the fluid from the soft tissues. This is different from that. The appearance may be the same, but the cause is different. Rather than the lymphatics, which are the soft tissue drainage not involving blood vessels being involved, here the veins are involved, and this is the swelling that is very, very hard to combat and really cosmetically awful for the patient. So enough about catheters. Let's go on to fistulas, which are truly the ideal vascular access for the vast majority of patients. You may have heard arteriovenous fistulas referred to as AV fistulas, or simply a fistula. What is a fistula? It's created by taking your own vein and surgically anastomosing it, is the medical word, or connecting it directly to an artery. There's no foreign material that remains in the patient. The suture material, which is used to sew the artery and vein together, typically dissolves over time. Many times patients get discouraged or frustrated because the AV fistula was created, but additional surgeries are required to help it mature or to be accessible. And I tell people, try not to get discouraged. It is time well spent, and if your surgeon needs to make it ideal, don't lose heart. Let your surgeon make it ideal, because in the long run it is so much better for you to have the AV fistula. Fistulas are associated with very, very few infections. There are some complications, and we'll get into those, but far fewer than you see with catheters. In the perfect scenario, a patient who has failing kidney function is identified, is referred to the surgeon, and starts dialysis with a working AV fistula and never sees a catheter. And again, these are the preferred accesses. These diagrams, or the top is the diagram, and quite simply, this is a cephalic vein fistula, and the surgeon takes the radial artery, which is the artery where most people tend to feel their pulse, down by your wrist, by your thumb, and the vein is isolated, meaning that they take the vein and cut it. The part of the vein that goes down toward the hand is simply tied off, and the part of the vein that it remains, that heads upward back toward the chest, is connected surgically to the artery. In the lower image, this is just a gorgeous fistula. You can see it's not enormous, it's good size, it's very superficial, easy for the nurses to identify where to place the needles. It's nice and straight so that you have a needle not taking the risk of poking through a curve. An absolutely beautiful fistula in that lower image. Here's where you get put to work. You need to monitor your fistula every single day. And ideally, you have a stethoscope at home that you can listen to your fistula. If you don't have one, I believe the dialysis facilities can get a hold of those plastic ones to give you. If not, they're very, very inexpensive. You can get them, I think, at places like CVS or Rite Aid. So the three parts of monitoring your fistula. Look at it. It's very important for you to look for change. Is it red, suggesting any areas of infection? Are there areas that are not healing? And sometimes if people have the needle placed at the same spot again and again, the area will be very slow to heal. There may be a scab that actually comes loose and leads to significant bleeding. So be sure to point out to your dialysis team any areas that may not be healing well. Any areas that the skin over the fistula appears shiny suggests that skin is very tightly stretched and is not very thick and is at risk for bleeding. And again, point that out to your dialysis team. They should certainly avoid sticking a needle into those shiny areas until they've been evaluated by your surgeon. Next is to listen. And I've listened to many thousands of fistulas over time, and the way I would describe it is, think about if you have your kitchen faucet and you turn the water on and the water's running, and you sort of play with the faucet so that the water is a little faster and slower, but still is constantly running. And the sound that you should hear when you take your stethoscope and listen to your fistula is a constant whooshing sound that is something like where you never lose the sound. If you have a very high-pitched sound or a whistle, that often signifies that there's very likely a narrowing, and that requires investigation. The last is just to feel your fistula, and you want to feel for vibration. The best part of your hand to use for vibration is just behind your fingers, where your fingers meet your hand, where you can feel the bones there. The bone is very good at picking up vibration. Rest that on your fistula, and you should feel what's like a cat's purring or like a motor running. There's a constant sort of humming sensation. It really shouldn't have much of a pulse to it at all. So if you feel a hard hammering, again, that's an indication that there may be an impending blockage and that the flow is not as brisk as it should be. And again, I'd encourage you to do that every day. So how do you know if perhaps there's a problem with your fistula? Well, if they're having difficulty placing the needles and your dialysis nurse says, it's getting more and more difficult to find the right place to place your needle. Many times when patients would come into the access center, and I was a medical director for an access center for 12 years, I was amazed at how narrow some of these accesses had become, and the nurses were still able to get the needles in. So they are very good at what they do, but I'd be very, very concerned sometimes that we might wait a little bit too long to have you come in and be evaluated. If your machine is alarming a lot during your treatment, of course, the majority of the alarms on the machine are due to pressure sensors, one on the arterial side and one on the venous side. So the first one, the arterial one, will say that the machine is meeting resistance, drawing blood out of your arm or out of your access and getting it to the machine. And more commonly is the venous alarm, which means that the machine is encountering excessive resistance, returning your blood back to your system. If you find that you're bleeding a really long time when the needles are removed, much longer than before, again, that will suggest a narrowing. If you get your laboratory reports back and you see that URR, urea reduction ratio, or KT over V, which is basically a very complex calculation that the computer does to assess the efficiency and the effectiveness of your dialysis. If those numbers are decreasing, but your dialysis treatment hasn't changed and you've stayed for your full treatment, then again, that suggests that there may be a problem with your access. If you have swelling in your arm, or pain that you didn't have before, and finally, if your fistula starts to enlarge and get irregular bulges, and this can happen with a graft as well, many times that needs to be evaluated by an interventionalist or a surgeon. You'll hear talk about stenosis, and stenosis is the medical word for a narrowing. And again, I think this is a very, very nice image, and this is literally exactly what it looks like. If you had X-ray vision and you could see through the skin and see what the vessel looks like, it literally looks like an hourglass, and the vessel narrows down. If you were to place your stethoscope over the point that is narrow there, where it says localized bruit, high-pitched systolic only, it would typically have a very, very loud whistling sound. And you may find that in between heartbeats that the flow actually stops, and that listening to it, you may hear rather than that constant sound that you should hear. Down closer to the thumb where it says distended hyperpulsatile, you may find that the access has a very hard pulse to it. I've had, in the past, I've had patients say, yeah, I have a great fistula. Feel how strong the pulse is. And that's exactly what we don't want to feel. That strong pulse means that, yes, there's good blood flow into it, but the blood isn't flowing out of it back to the chest very well. These images are from an interventional procedure where a stenosis is treated. If you look at this, there are two panels, the upper and the lower, and on the upper panel, the lower dark blood vessel you see is the artery, and the blood, of course, makes a U-turn, and where you see that small arrow, that's one side of stenosis. There's narrowing all the way up there, and I think it's pretty obvious for you to see. If you go to the lower panel, you can see the result after a balloon has been passed into the fistula. The balloon has been dilated, and now that fistula is wide open. And that's radiographically, that's an absolutely beautiful result. And that's what we hope to see when we have you come to the vascular lab. Okay, so again, the upper panel is before, and the lower panel is below. There's a question in here about what causes stenosis. That's a long answer. There are many things that can cause stenosis. Typically, they can occur at a site that is cannulated with a needle again and again and again. Turbulent flow will cause a stenosis, and many times with no through no fault of the patient or the dialysis team or anyone else, where the artery and vein are connected is often a very sharp angle, and that angle will often promote a reaction within the vein that leads to stenosis. Sometimes typically high flow can lead to a stenosis as well. Okay, I hope that's responsive to your question. Moving on now to grafts, and many times people will have a graft because their own blood vessels are simply not conducive to creating a fistula. If patients have poor veins, or let's say we have somebody who has received chemotherapy in the past and the veins are very scarred, for any number of reasons the vein may not be ideal. Think of a graft as a synthetic vein, and in the same way that the artery and the vein are connected for a fistula, well, this synthetic material is connected to the artery and bypasses a problematic area of vein and is then connected to a vein at a place where it can drain well. Most commonly, we see grafts in the arm, but they can be placed in the thigh, in the chest, basically anywhere where you have access to blood vessels. I won't dwell on this, but there are several different graft materials available. They differ in that some of them actually allow use cannulation on the day that the surgery is performed, and I think that's a separate talk about those materials. I think this is a very nice schematic about grafts. This is what's called a forearm loop graft because it is in the forearm. It goes from the brachial artery or the proximal radial artery to the cephalic vein in this case, and you can just see where the whitish material, which is the graft, is connected to artery and vein in a loop configuration, and they even show you how the needles are placed, and that I thought again that was just an excellent depiction. My understanding is that this slide deck will be made available to you, so you'll have that to look at yourselves at home. Well, what are the benefits of a graft? Even for a graft that you have to wait for it to heal in before you can use it, typically that wait period is only 2 weeks. There's not really a maturation period. The graft material itself doesn't change, but it heals into place during that 2-week period. It's an excellent option for people who have veins that won't permit creation of a fistula. And one of the things that is very nicely spelled out again in the revised Kadoki guideline is that if a graft is placed in the forearm, of course the drainage from that graft is going to be through the veins in the upper arm. And as those veins in the upper arm develop with the high blood flow, one of those veins will probably become an excellent candidate for a fistula in the future if there are problems with the graft. Again, with proper care, a graft can function and last for many, many years. A HERO graft, and again, HERO stands for Hemodialysis Reliable Outflow Graft. This was devised for people who have problems with veins in their upper arm and chest that would not permit a graft to be placed in the arm. Many times, if the patient has central vein stenosis, as we described earlier, that will be the primary reason that a HERO is used. And there's a graft in the arm, very similar to what we displayed in that previous image, and then a tube that actually continues directly to the heart, bypassing the veins. We have a nice image of this, and thank this gentleman for posing for us. The whitish material that you can see is where it says graft component. That's the same material. It's actually Gore-Tex, the same stuff that they use in making raincoats. And then centrally, it is basically a hard plastic tube. The tip of this sits literally in the heart, and it bypasses any narrow veins in the arm, the shoulder, and the neck and chest. Okay, here are the take-home points from today. Number one, since you called into this, you are now going to be put to work, and you need to check your access every day. If you find that it is frequently having issues, ask the question and say, what's next for me? What do I need to do next to make sure I never have a lapse with my access? Do the look, listen, and feel every day, and be sure to report any changes to your dialysis team. They are about the most busy people you will ever run into, and when a dialysis patient speaks up and says, I have a concern, I'd like you to look at this, you serve as their, I call it auxiliary eyes and ears. It's invaluable for you to do that. If you do have a central venous catheter and it's possible for you to have it removed, by all means inquire and request to have that done. If your first fistula surgery wasn't successful, be persistent. Current data show that 62% of the time a second or perhaps third procedure is needed before a fistula is functional, but then it's functional and it's worth the investment in time. And there are many, many resources out there. The biggest one you've already dialed into, which is DPC. As you know, they have a very, very active educational arm. The National Kidney Foundation has fantastic resources available to you. the American Association of Kidney Patients, and don't hesitate to ask your dialysis provider. Most of the dialysis providers have fantastic resources as well that they're more than happy to share with you. One thing that I really like about the National Kidney Foundation site, and you can't forget this kidney.org, they have a patient-centered area on their website, and they will send you all of their publications, one copy for free, which is really very nice. And I believe that that was it. One chat from a former patient of mine. Good to hear from you as well. Very pleased that you were able to join us. So with that, I don't know if they plan to open the voice lines for questions, but we also would be delighted to take your questions via chat.
Thank you so much, Dr. Mahoney, for sharing all of that great information. You do it in such an easy to understand way. So
you would think I had done this before.
You know, I've heard a number of talks. I'm learning more every single time. I just like some of the ways that you said things. It's like, that's a great way to remember some things. I know we have a few questions. I'm not sure, Hillary.
I'll go to the first one on the chat here. I don't know if everyone has their chat box open, so indulge me. I'll read the question. What are risks with balloon angioplasty? Great question. When I trained in 2006 to do interventional work, one of the really scary points that was brought home to me was when you do an angioplasty with a balloon, you are tearing a structure. Ideally, you're only tearing a scar and the wall of the vein remains intact, but still you're tearing a structure. And so the most serious of complications with a balloon angioplasty is that the vein actually ruptures and that there is bleeding around that area into the arm or into the chest. Now, that doesn't necessarily mean that it's a disaster. I certainly have had extravasations and have had veins tear, and that's the situation where a stent is put in place, which is basically a piece of Gore-Tex with a metal mesh inside of it that provides a tube that will cover that hole created in the vein and allow the blood to pass where it should and not extravasate out into the arm or chest. Now, other risks, whenever there's any procedure, there's the risk of infection. And again, I think that is brought down very, very low with all of the sterile precautions taken. Where there's the risk of infection is if a graft in particular is infected. And so be sure if you are sent for an invasive procedure and you notice redness or have noticed certainly any drainage, any exudate, any pus draining, be sure to bring that up because typically we will not do an intervention in the setting of an active infection. Other potential complications, people may be allergic, not to any of the equipment or supplies that we use, but to some of the medications. Some people are allergic to iodine and can't tolerate the contrast that's used. We do try to pre-medicate and avoid that. I think those would be the biggest risks. So bleeding and infection. Okay. The next question is, what are some of the benefits of self-cannulation and pros and cons of buttonholes? Well, self-cannulation means that you're self-reliant, which is a good thing. And for people who do home dialysis, which we absolutely support and hope people will pursue, you either have a healthcare assistant helps you with your dialysis, or you're cannulating yourself. The problem with buttonhole is that there are two. One is they are more easily infected, and it's very, very hard to make sure that that tract stays sterile. The other thing that I have seen with buttonholes is that in the process of creating that buttonhole tract, there is scarring, and the scarring ends up leading to areas that promote clot formation. And so many times I've seen very, very large organized clot that forms because of buttonholes. So infection and clot formation would be the cons for that. The pros, again, are number one, it's not a sharp needle and it's more comfortable for you. And number two, you're self-sufficient. There's a comment here, or a question and a comment. Is a hero something that is commonly placed? I guess it depends where you live, and you've alluded to that in your question, where you said none of the local surgeons place hero grafts. I practiced in the Northern Virginia area, in the Washington, D.C. suburbs, and we had fantastic vascular surgeons, and they did a beautiful job with heroes. I think the thing to do is to inquire, and again, the local dialysis network does a lot of work with surgeons, and you may inquire with your local network as to where can they recommend that you go to see a surgeon who not only places hero grafts, but places them well and has a lot of experience with them. So I think the network is a grossly underutilized resource, and trust me, they are delighted when people call with questions. Next question here. For home hemo, what can be done to extend the life of a fistula? Ideally, when we talk about extending the life of a fistula, we talk about rotating sites. And again, for someone who does buttonhole cannulation, that's not going to happen, but that's a different concern. I guess I would extend your question to, well, what causes a fistula to have a shortened lifespan? And it is probably when there are unrecognized problems, unrecognized stenoses that lead to clots and so forth. And so on your machine, your dialysis machine, there will be venous pressure, which again is the pressure that it takes for the machine to return, to overcome, to return your blood from the machine back to you. How much resistance is there? If that number rises, then you know, well, you may be developing a narrowing in your access, and that's a reason to inquire. And if you can prevent clotting of an access, you can extend the life dramatically. I think that the home dialysis nurses do a very good job at teaching you to be independent, but one of the ways to be independent is to learn which important questions should you ask. And when you have your meeting with the home team, ask them, what are my venous pressures doing? What's my KT over V doing? Is there anything to suggest to you that my access is having a problem? Have them examine your access when you see them and ask them, does it have a whistle? Does it have an abnormal bruit? Again, have them do the look, listen, and feel while you're there. And again, the network and the National Kidney Foundation have excellent, excellent resources on how to examine and how to troubleshoot your access. Avoiding infections is key. And so I cannot stress enough the importance of getting your flu shot and staying well. I got mine a week ago. I was surprised it's available so early, but please, please, please get your flu shot as soon as possible. I'm going to look at the next question. Oh, what a great question. I'll read you the question. I'm a kidney transplant recipient, congratulations, by the way, and volunteer/patient educator at a dialysis clinic. Would it be okay to share these slides with the FA? It's okay to share these slides with everyone you've ever met. So yes, please, with your FA, with patients you've worked with, anyone. That's the whole purpose of preparing these for DPC. And Hillary, I guess you've already given the link, so that is great. But yes, please share them with everyone you've ever met.
Absolutely. There was a question earlier when you were talking about the catheters. There was a question that that was asking if the inflammation from the CVC can cause sepsis.
What a great question. Typically, people think of inflammation as being a sign of infection, and it can be. Inflammation doesn't need to be associated with infection, though. And think about when you had, for those of you who had a graft placed, you probably remember your arm turned pretty red for the first few days, and there was a concern that it might be infected. That was an inflammatory response that your body had to that foreign material being there. When a catheter goes in under sterile technique and assuming that everything is kept sterile, the inflammatory response is your body's response to recognizing that a foreign body is there. It does not set into play, though, that cascade associated with sepsis. So typically, no. There is an inflammatory response, but it's not that severe inflammatory response that is associated with sepsis.
Okay, thank you for that. And it's great to hear people talk about sepsis and to know what it is and that it can happen. So that was great to hear as well. And thank you for the encouraging people to get their flu shot. That was an added bonus here at the end.
There's one. I'm sorry. There's
like
an
one
additional
more
comment here in the chat that I would like to comment on, where someone wrote in, I have a fistula for a year, not on dialysis, yet my numbers rose back to a normal range for me. That is fantastic, and I know that sounds as though, 2 more miracles and you can be canonized, but I actually have seen that in the past, that people get an access, and for whatever reason we see an improvement in their numbers. My guess is that you're probably somebody who's taking pretty good care of yourself, and you should be complimented for that. The really great thing is, if someday, and hopefully we'll never see that day, but if the day comes that your kidney function declines again, you do need to start dialysis, you have been able to avoid all of the complications that come with catheter use. And so I think that is absolutely great. What I would advise you to do, though, is to monitor your fistula very carefully. If you see that it starts enlarging significantly, that may be a sign of 2 things. One is that it may have developed a partial blockage, and 2 is that it may have developed an excessively high flow. And accesses with extremely high flow can actually lead eventually to some cardiac problems, some heart problems. And so despite the fact that it's not in use, it's probably good to ask to have your access ultrasounded once a year, just to make sure that it doesn't have sites of narrowing and that it does have a normal blood flow rate.
Another question that came in was, you had mentioned that 80% of new patients start with a CVC. Is that in the U.S., elsewhere, globally?
Those are U.S. data.
And then another question was, with access stenosis, what is the side effect after surgery?
I'll assume that by surgery they mean an intervention like an angioplasty. The great thing about that is it's all done through a needle, and so the needle is removed. You have one suture, one stitch in place, and you really shouldn't feel anything except better. Occasionally, I've had people say that they had a little bit of pain, especially if the vein that was narrowed was up in the chest, that they had sort of an ache in their chest for a day or so afterward. That's a small minority of patients. Typically, once people leave the center and are home, it's very unusual for them really to have much of anything in the way of symptoms. One thing that is very important, if you leave the facility, the procedure facility with a suture in place, you really want to get that out somewhere in the 2 to 3 day range. You don't want to leave that in place for more than a couple days. Okay, there's another question here about how long do cadaver grafts last, and I'm by that, well, I'll answer two questions. I'm not aware any longer of a cadaveric vein being used for dialysis access, so I have no familiarity with those. People do refer to a transplanted kidney as a graft and a cadaver graft. That's highly variable, and interestingly, we used to tell people that if they got a transplant, they could anticipate that they would need it for about it would function for about 7 years, and then they would need another transplant. Unfortunately, that came from back in the days where we ran the levels of the immunosuppressive drugs a little too high. And now with better drugs and better regimens, kidneys can last as long as the rest of you does. I hope that was responsive to your question. Oh, I see you're typing again. I guess so.
I guess it was. Okay, any last questions? What a great discussion, and great questions.
I would just like to make one last point. First of all, to thank you so much to everybody who joined us. We have 90 attendees. That's not my own personal record, but it's awfully close. That I'm hoping that this presentation today will stimulate some thought and some curiosity, and that you'll have further questions. I'm always happy to answer them. I'm very easy to contact by email. It's david.mahoney@davita.com. Always happy to answer questions by email. And don't be shy to ask your dialysis team and your nephrologist as well. I would like to point out that sadly, most nephrology fellowships do not involve a great deal of training in vascular access. And so your nephrologist may say, you know, I really am not the absolute expert on this. Please reach out to DPC and to the NKF and the network, because they'll put you in touch with somebody who is.
Yeah. The slides will be put on our website within the next few days, within the week for sure. And if you registered for the webinar, you will receive an email from Hillary that will take you directly to the link. I'd like to thank everyone for attending today and for your participation. Please complete the feedback form that comes up on your screen at the end of the program. And just a quick reminder that our September 24th webinar will be in Spanish, and it'll be on managing blood glucose. And thank you, everyone.